maybe the way to start is, and this is very specific to the work that I do, so I don't want to answer outside of that. I think where we start is we start by humbling ourselves as physicians, at least in the work that I do, to understand that the greatest benefit that we do is witness. It's not treat.
Yes.
It's not a medication.
Witness.
It's not an intervention. We witness. And it's amazing to me to watch patients as they near the end and as they're dying, rather than reaching out to the ones that are closest to them, like family, to tell their story and to have someone around who can observe and witness the significance of not only the events that have happened, but what has gone on before, is a total stranger. And ends up often, if the physician is open to it, to be the physician. And it's a humbling experience to realize that I can't say everything's going to be all right, because it's not going to be. And I can't make promises that I can't keep. But the promise I can keep is to sit and to listen and to experience that. And then I can bring all the rest of my armamentarium with me. If I've started with witness, then I think I've begun to truly know who I'm taking care of. And I can personalize that experience so that the whole way that I do things no longer is at a distance, and it no longer is separated from them, but I walk alongside them. And I think that changes not only the way you communicate, but it changes, I think, the decisions that physicians make.
You know, I have to say that I don't think that physician education is the answer at all. We had a 10-year period from the time the support study came out to 2005, when Robert Wood Johnson, Open Society Institute, all grant makers in health, they spent about $350 million on physician education. And it still is tremendously lacking. We don't actually have any measurable improvement in patient-physician communication for all of that. I think that physicians, the medical community, is reactive, it's not proactive. And what it reacts to is changing expectations in the environment of their patients. If you talk with people, physicians who have had this transformational experience and they are now good communicators, it's because of something that they learned from their patients. It's like the natural birthing movement. It's not because obstetricians decided, gee, we're going to change the way we practice deliveries, we're going to create home-like environments, very family-centered, much more natural, less anesthesia, et cetera. No, it wasn't that at all. It was because women said, we are tired of this high technology, of this impersonalization of what is a natural life process. We want to reclaim birthing. And they did it in such a way that the medical establishment responded. And now we have providers competing on the basis of how home-like, how family-centered an environment for birthing they can provide. Well, I think it's going to be the same thing for deathing.
Deathing, I just learned a new word here.
We have to change the expectations of the people and pull the medical community, because you can't push them. You'll have to pull them because society expects a more natural, a more home-like, family-centered, patient-centered dying experience, and that's what we demand.
Millie?
So following on that, what are the things that patients and families can do to encourage that kind of response in clinicians? And I think partly it's giving the clinicians permission to share their uncertainty, to say, look, I realize we might not be clear about the prognosis, but I want you to lay out all of your thinking. I'm not expecting you to tell me black and white answers. I think many clinicians don't know they have that permission, and patients and families can actually give it. I think that there's, along that same line, not just uncertainty, but try to help me understand what might happen after I leave here. I've already mentioned that. There's a lot of things that we can do as patients that encourage the sort of conversation that we've been talking about, and that speaks to the comment that we heard earlier about contemporary issues. Often are families demanding things, and the doctors not really knowing how to, getting into conflict about that. And so that's another thing that the public can take hold of and say, more technology is not necessarily in your loved one's best interest. And how can we be more sophisticated in our understanding of how we take great benefit from the amazing advances in science and technology that are breathtaking, that we want to be doing, and minimize some of the burdens that come with that. That's going to have to be a voice that comes from the public and creates more trust in that clinical encounter.
And Sam, you get the last word.
You know, I'm a intensive care doctor, works in a children's hospital, and families of children who are sick and might die aren't ready for deathing. So it's a little bit different, but I can tell you in my experience, people who manage death regularly, intensive care doctors, palliative care doctors, develop very good communication skills in managing families and trying to address where they're at in their communications. But the reality is the vast majority of doctors in the healthcare system do not have experience in managing death and dying. And so to expect them to have communication skills in this area is naive. It's not going to happen. And so what I hear throughout all this discussion is that currently end-of-life care services are inadequate in society, either in the hospital or at home, and investment in end-of-life care services for those families who require it perhaps is one of the things that we need to do. But communication comes from experience, and if you don't talk to families with dying patients, you don't develop it, so don't expect it. Don't expect it from your cardiac surgeon, don't expect it from your brain surgeon. What you want from them is good hands and good decision making.
We have many more questions, but no more time. Thank you so much to the panelists. Thank you, all of you.